applications of the NeuroZoomer Plus test for patients with neurodegenerative conditions. One is to monitor, how are we doing? Patients doing really well. Are we missing anything? Let's do a check-in with a NeuroZoomer Plus. Patients aren't going to go for MRIs, every 3 months to check in on things. MRIs, if they progress one way or the other, they tend to do that slowly. So, it's like, oh, we're going to check in after a year, maybe a couple of years if things are stable, at least here in Canada, we're, on a socialized healthcare system. So if things are stable, like they're not going to do MRIs yearly if not needed. So they might get spaced out more. With a NeuroZoomer Plus, we can check that blood work anytime we want. Now, it's not a cheap test, so we're not, doing it like once a month or something like that. But we can check our progress and get more biochemical insight and kind of updates in terms of how good of a job we're doing. But then we can also use the NeuroZoomer Plus to see like what's going on here, like what are we maybe missing? Is there, if there's atypical cases like this one where it's like there seems to be something we're missing here. Well, oh, we found those anti-voltage gated potassium channels. And then, as I also referenced earlier, we also can use this testing if, say, there's a bit like I have another patient right now who is having a lot of really debilitating neurological symptoms, and yet like MRI is looking good, spinal tap looks good, CT scan looks good, blood work's looking fine. Gone to see several specialists, can't seem to find anything wrong. So like, well, we're going to do this test, and so because we want to see like, are we missing something at a biochemical level? And actually, we got those results back already, and like quite a lot of stuff lit up there. So it can be very, very useful tests when there are otherwise kind of unexplained neurological symptoms. Of course, there are going to be cases where I have another patient where, we did this test, history of complex chronic illness, did this test, got the results back, and it was kind of like the results were a little bit meh. It was like maybe there's some things we can work on here. Like there were some things that were off, but like there was nothing that really lit up like, oh, this is definitely what's going on here. So there are certainly going to be those anticlimactic cases where it's like, oh, I spent $420 US on this test, and then it came back showing, like, this isn't really giving us anything to like really confidently sink our teeth into. Although there was, not to say it wasn't useful. There were some angles. It just wasn't quite as like cut and dry as say this report, where it's like, oh, we're really quite optimistic that these anti-voltage gated potassium channels are explaining the symptoms because they can cause the exact symptoms you're dealing with. So, anyways, no test is perfect, but I think this is a useful one in the right context. All right. Man, I really thought I was going to be done this video in half an hour and haven't even got to the next report yet. So there, once again, I have underestimated how much time it takes to go through these things. So let's see here. Yeah, for the rest of the report here, the brain autoimmunity section. Yeah, let's just pay attention to the anti-amyloid beta here, not because it's relevant for this patient at all, but just I'm going to talk about this for the next patient. So just maybe keep your eye on this for a moment. So the brain autoimmunity section, not seeing any IgMs here so far. Numbers are not that high, again, want it to be less than 10, 10.7, like 11.7, 13, nothing too major there. But just anti-amyloid beta. So these are antibodies that can be, so amyloid beta is the type of protein aggregate that occurs when, or peptide aggregate that occurs when, like as part of the pathophysiology of Alzheimer's disease. So we really don't want excessive amounts of amyloid beta. And so with this patient, despite the fact that they have a, many year history, I think the MS diagnosis has been like at least 10, if not 15 years old for this particular patient. So, long-standing MS diagnosis, lots of symptoms, and yet anti-amyloid beta looking very insignificant. So let's see how that looks in the next patient. And again, this patient is very mentally sharp with it, not having any signs of cognitive decline that has been reported to me or that I've observed in practice. Of course, sometimes patients don't report things, and you kind of see as a clinician, it's like, like you can tell that this patient's like not as sharp as they maybe once were, or like you assume that they're maybe not as sharp as they once were if you just met them for the first time. But with this patient, like just very mentally sharp, and yeah, there's no signs of any like pre-dementia or anything like that I have any inkling of with this patient. So Let's see here. Yeah, so a couple of other levels. The anti-dopamine receptor 2, like, kind of getting into the mid-teens there. So maybe something a little bit more relevant there. But again, like no IgMs and just none of the levels are super highly elevated. And there are lots of brain inflammation antibodies in this section. So there, one, two, five out of I want to say there's at least 10 anyways. So that's yeah, something that does not seem to be overly surprising given the nature of what we're seeing. Like, yes, it'd be surprising if we didn't see any brain inflammation markers, but they're IgG and not super high. So again, it does look like we're doing a pretty good job actually taming the inflammation in general, but just not those potassium channels as mentioned. Then the last section here, Epstein-Barr. So when we see, to my understanding, when I see IgG to the Epstein-Barr nucleic antigen and the Epstein-Barr viral capsid antigen. That tells us that there's been a past exposure to Epstein-Barr, and that makes sense, especially in the context of MS, because Epstein-Barr seems to be a trigger for MS pathophysiology development. But where we're not seeing any elevated Epstein-Barr IgG early antigen, then that would suggest that there's not an active infection going on. So also, it's like an indication that we've probably done a pretty good job with the antimicrobials that we've used with this patient over time. Unfortunately, they haven't helped at all, but at least on paper, there's no active, viral picture happening here. So it's, not patting ourselves on the back for like doing a great job when there hasn't been any clinical improvement, because that just sucks. Pardon my crudeness there, but it just sucks. But evidently, we have done a good job, at least on paper. So very, very small recompense for not feeling any better, but at least we're getting some confirmation that, okay, it's not that we've just missed the boat or missed the mark, I should say, with like, oh, we just need like stronger antimicrobials. Like if this patient's result came back with like just this full microbial profile where it's like, oh my gosh, everything's just off the charts high, and then it would be like, oh, maybe we just were not successful with the herbs and the intravenous ozone and different things we worked with, but everything's looking pretty sleepy on an Epstein-Barr virus level. So that suggests we've actually done a pretty decent job on that front. The anti-HSV1 antibodies are highly elevated, and that's something that just happens when we have history of cold sores. And then elevated strep, very common to see those elevated, especially in a history of autoimmune disease. And then just seeing that there's this Epstein-Barr virus antigen, but again, there's not that elevated IgG early antigen, so we're really not worried about that. So that is that report. Moving on to the next report. So again, this patient generally healthy. Okay, so patient is somewhat overweight, a bit more sedentary than is ideal, although they're working on it. Some blood sugar dysregulation, around some blood sugar control medication, and then having some mild memory and cognitive impairment. So not the healthiest person on the planet, but they don't have a history of complex chronic illness, and they are just, I feel like, representative of your, I don't know, I guess you're kind of like classic person who's like not doesn't have a history of complex chronic illness, but they're maybe haven't taken the very best care of themselves leading into their 60s, and they're having a bit of cognitive impairment. So I feel like this is probably describes a lot of people that are out there, and so this is how a NeuroZoomer Plus can apply to a patient like that. Now, with that being said, I mean, this patient is doing good things, like on there's additional good things that they're doing, such as like having a good like they have a good meditation practice. They go for regular body work. They eat organic food. Not always making the best choices around like portion control and steering away from carbs and things like that. But eating like generally like organic food and things like that. So they are, making they're not the standard North American, individual. They have certainly more things going for them than the average person, but I still feel like they're fairly representative of folks in that demographic category. All right. So, yeah, demyelination section, seeing that antitubulin. Honestly, I've looked at a lot of these NeuroZoomer reports. Antitubulin comes up all the time in the IgG orange section. So I certainly pay attention to it, but it's not. It's rare that it doesn't come up. So it seems to be a low-hanging fruit for the immune system to start reacting to. But again, only one of the several demyelination antigens. I'm really not worried about that at all. Taking into account that, like, okay, there's a little something there, but not not like this notable notable demyelinating picture going on. Blood-brain barrier disruption. Um, so, only a couple of markers coming up here, but just interesting that they're both IgM. Now, levels are quite low. 10 or above, or 10 or lower is considered normal. So they're only at an 11 here. But again, this patient's generally healthy, and then we're trying to, as Wayne Gretzky said, you want to skate to where the puck is going. So if we see that, like, okay, there's some IgM here, then why is that happening, and like, what might this lead